Can you hear me? Everything is okay? Okay. We can start it. Today, how I care program that organized from the Tehran University of Medical Sciences International Vice Chancellery Office and School of Nursing and Midwifery, Pediatric and Intensive Care Nursing Department under supervision of the leading house for Iran, North America, and Canada academic partnership. It's my pleasure to be given this chance to act as a moderator in this program. I am Dr. Marzieh Hassanpour, PhD and Professor of Nursing, NITA professional and member of the leading house for Iran, North America, and Canada academic partnership, working at Pediatric Nursing and Neonatal Intensive Care Nursing Department in School of Nursing and Midwifery, Tehran University of Medical Sciences, Tehran, Iran. I am extremely grateful to all of you, respected colleagues, professors, researchers, and students for registering and participating in today's scientific program. Your presence is greatly appreciated. You are very welcome to this scientific, very valuable program that we have the Dr. Ali Zarrabi from USA. I would like to express my gratitude and appreciation to all the people who have helped and supported the planning and implementation of this program at the university's International Vice Chancellery Office and School of Nursing and Midwifery, as well as the Department of Pediatric Nursing and Neonatal Intensive Care at Tehran University of Medical Sciences, especially engineering Ms. Sadeghi helped us and her team. The program will be recorded and made publicity available on YouTube. So please, participant notice, write and ask your question in English in chat box or raise your hand in the end of the presentation of Dr. Ali Zarrabi. I would like express my sincere thanks, and it's my privilege and honor to acknowledge Professor Marjan Yaghmai as a facilitator who assisted and supported me in organizing this program. Professor Marjan Yaghmai is Professor of Medical Genetics and Head of Leading House for Iran, North America, and Canada Academic Partnership, who is working at the Hematology, Oncology, and Stem Cell Transplantation Research Center, Research Institute for Oncology, Hematology, and Cell Therapy, Shariati Hospital, Tehran University of Medical Sciences. I think she is attending this program now, and I would like to express my sincere thanks one more time to her and all support in this program and me. We have in this session as a panelist also Professor Ali Akbar Nejati Safo. Then also it's my privilege and honor to acknowledge and introduce Professor Ali Akbar Nejati Safo, who is assisting me to lead today's program as a moderator. Professor Ali Akbar Nejati Safo, medical doctor and professor of psychiatry, who is working at Division of the Psychosomatic Medicine Department of the Psychiatry, Tehran University of Medical Sciences. He is a professor of psychiatry at Department of Psychiatry, School of Medicine, Tehran University Medical Sciences. He also has the following positions at the moment. Deputy of Education, Ruzeh Mental Health Hospital, member of the National Board of Psychiatry, member of Board of Directors of Iranian Association of the Psychosomatic Medicine, and also his research focuses on psychosomatic medicine, including psycho-oncology and the organ transplantation, psychiatry education, and cognitive behavior therapy. He has published numerous research papers in the reputable scientific journals and also the book chapters. Dr. Ali Akbar Nejati Safo, very welcome to this program, and thank you so much helping me leading this session. Finally, at the last but not least, I am truly thankful and privileged to present and recognize Dr. Ali Zarrabi, who I encountered and met him At the McGill International Palliative Care Congress 2024 in Montreal, Canada, he graciously agreed to collaborate with our university and has also accepted my invitation to present and share his expertise, research findings, and experiences and on psychedelic-assisted therapies for complex suffering in palliative care with us today. Dr. Alijan Zarrabi, very, very welcome. I have to a little bit more talk about the brief bio of the Dr. Alijan. Dr. Alijan is the assistant professor working at the Division of Palliative Medicine, Department of Family and Preventive Medicine, Emory University School of Medicine. Program director also is the Palliative and Supportive Care. Dr. Alijan Zarrabi is a medical professional and a scientist who served as an assistant professor at Emory University School of Medicine located in Atlanta, Georgia, USA. He holds the position of Program Director for Palliative and Supportive Care at Emory Center for Psychedelic and Spirituality. He earned both his undergraduate and medical degrees from the Brown University through the program in liberal medical education. And additionally, he completed a residency in internal medicine and a fellowship in palliative medicine at the Icahn School of Medicine at Mount Sinai. His clinical teaching and research interest center on aiding adults in their healthy adaptation to life-changing illnesses, primarily in outpatient settings. His research addresses identifying biopsychosocial and spiritual needs among the seriously ill and studying the role of the emerging medication and psychotherapy to treat complex distress. Dr. Zarrabi, very welcome to this scientific program. We are keen and enthusiastic to hear from you. If you have if you can hear me, podium is yours now. Can you turn on your microphone and start your presentation on the title of the Psychedelic-Assisted Therapy for Complex Suffering in Palliative Care. Thank you very much. And thank you everybody joining this very fabulous and inspiring session. Hopefully you can share and write your experiences, question in a chat box. And if you wanted to talk and speak, you can just raise your hand in the bottom of the Zoom screen, and then a microphone will be available for you, and you can just, as a live question and answer, do with the Dr. Zarrabi. Thank you very much, everybody. I can turn on my microphone, and Dr. Ali Zarrabi, we are at your services and hearing your voice, hopefully your presentation. Thank you very much, everybody.
And thank you very much for the very generous introduction, Dr. Hassanpour. So the title of my talk is Psychedelic-Assisted Therapies for Complex Pain and Suffering in Palliative Care. So in the next 45 to 50 minutes, I'll describe the role of these therapies in palliative care, as well as other settings, psychiatry and oncology. Identify challenges to using these medications combined with psychotherapy. These medicines in the United States are Schedule I drugs, meaning that they are illegal to use outside of clinical trial settings. These medicines are also believed to have religious and sacred significance for a variety of communities in the United States, and some of those communities have the legal right to use them. However, people who are not members of these religions are not allowed to use them. And finally, I'll describe findings from a clinical trial that I conceived of and led. I am part of this center at my university. We call it the Center for Psychedelics and Spirituality, because these medicines have historically, for thousands of years, been used for spiritual and religious purposes. And we are conducting them within psychiatric and palliative care settings. So what I study is the role of psilocybin, which I will explain to you in a minute, for cancer patients with hopelessness and with chronic pain. We also study these medicines for depression, including postpartum depression after pregnancy, for PTSD, particularly in veterans returning back home to the United States from wars. And we're also looking at how to integrate these therapies into people at different transitions of their lives, including people approaching the end of life, as well as studying their harms. So what are psychedelics? So the psychedelics are typically any medicine that alters your consciousness. And historically, in the English language, they've had many names, from hallucinogens to medicines that mimic psychosis to mystical state-inducing experience, like mystical mimetics, or entheogens, medicines that elicit a divinity within you. For the purposes of this talk, I will just call them psychedelics. Classic psychedelics include these four medicines, or I would say compounds. These chemicals are psilocybin, LSD, mescaline, and dimethyltryptamine, and they bind to the serotonin receptors, specifically the 5-HT2A receptors, which are represented in the central nervous system, as well as in the gut. There are other medicines, of course, that can occasion hallucinations or non-ordinary states of consciousness that are not serotonergic. And those include ketamine, which can be used as an anesthetic, as a pain medicine, and also in the United States is increasingly used, and in Canada as well, to create these non-ordinary states of consciousness for the purposes of augmenting psychotherapy. There's also ibogaine, which is from the West African shrub in Africa, which people are now using, particularly veterans with PTSD returning home from war. They are traveling to Mexico to receive this treatment because it is illegal in the United States. There is MDMA, which is an empathogen. It makes people feel more connected to each other, which we are using primarily for PTSD. Cannabis can even be used as a non-classic psychedelic. And finally, an Iranian uh, plant, isfand, is a non-classic psychedelic. And when consumed, if you drink the tea of isfand or wild rue, it is a monoamine oxidase inhibitor and can occasion these states of consciousness. In the West, we have not studied isfand in clinical trials, though perhaps that could happen in Iran. So these medicines, these classic psychedelics, all have this indole structure, if you remember your organic chemistry, which are found in the classic psychedelics on the top row and on the bottom left, but not in the other structures like MDMA, ibogaine, and ketamine. These medicines we are using synthetically primarily in our trials, but they come from the plant world and the fungi world, and you'll see that toad right there as well. On the left is the Banisteriopsis copyvine, from which a monoamine oxidase inhibitor is extracted and is used in Brazil and other South American societies to create the brew ayahuasca for ceremonies. On the top, you'll see that gland to the right of in this image of this toad. And in that we can find 5-MeO-DMT, a very potent psychedelic, which we are studying in clinical trials for depression. And that research is funded primarily from the United Kingdom. Below is the peyote cactus, which contains mescaline, which is used in Native American ceremonies in the United States. And to the right is what I study for cancer patients and palliative care patients, which is the Psilocybe cubensis mushroom. This mushroom is not indigenous to Iran. It is found primarily in other parts of the world, including in Africa. And psilocybin is extracted from it, which is what we study. I'll say this again. So on the left, you see the Banisteriopsis caapi vine that's used in ceremonies in the Western world, and it has the same active ingredient, harmaline or Pegamum harmala, that is found in Esfand. These medicines have been used for thousands of years. In our museum at my university, we have these structures with these mushroom caps. It is believed that the figure on the right is a medical healer with Klinefelter's syndrome, an intersex figure. And these medicines were used as part of healing ceremonies in these early societies. In our trials, however, we compound them and we extract it and create a purified form in a capsule that we can study. And really want to drive this point home that these can be endangered species. This vine that I showed you is being over harvested, and that is why we create these synthetic compounds for our trials. So how do they work? They increase functional connectivity in the brain. They decrease blood flow to the default brain network. And this is the part of the brain that creates narratives about ourselves. And temporarily, at least with psilocybin, for 4 to 6 hours, this is decreased. And this self-referential ruminative part of our brain is essentially released from its function. So new narratives could potentially be formed, and psychotherapy, the role of cognitive behavioral therapy or meaning-centered psychotherapy can potentially be enhanced, and people can find, people classically say it feels like thousands of hours of therapy in one day. In terms of psychological mechanisms, mediators of benefit include the sense of a mystical or spiritual type experience, a feeling of a breakthrough, an insight. And with those, you feel this ability to avoid things that seem to cause you psychic trauma less. You're able to lean into those things and experience them without the same fear. Mystical experiences are the domain of religious studies, so it is challenging to study them in scientific contexts. We do use these scales to measure the degree of a mystical experience within our clinical trials. For example, to what degree did you feel like a sense of reverence or sacredness, or that no word could capture what you felt, or this sense of unity between you or perhaps other beings, or to nature or to God? These are ways in which we measure this construct of mystical experience. And these experiences are not always positive. Some people who go through these trials find that these experiences can cause them even more anxiety and depression, which we are currently studying. It is rare. It's about 1 in 23 experience these kinds of bad experiences. And you can read more about them in for example, this piece in the Harvard Divinity Bulletin. So in palliative care, I want to introduce you to Bill Richards. He is a psychologist who's been doing this work for probably 60 years. And there's a clip of him and his views of why he thinks this is important for cancer care and palliative care, which I'll show you. It's just 1 minute.
And that's
so
got the FDA approved GMP stuff.
Yeah.
And we're not going to arrest you for growing mushrooms.
That's right. What drives me personally, as I mentioned earlier, I found working with these cancer patients, end of life issues, just so incredibly meaningful. I think it could change the way the whole culture approaches death, really, ultimately. There's no need for all this depression and withdrawal and pain that so many people go through.
Right.
But for that to really happen, oncology centers need to have palliative care centers where they can legally provide psilocybin with skilled people. in the right dose, in the right purity, and it needs to be covered by Medicare. You know, it needs to be fully incorporated. So, as I'm fond of saying, the poor inner city resident who is suffering, whether from addictions or anxiety at end of life, who doesn't have a tie-dye t-shirt, you know, and can't spell psilocybin and isn't interested in learning how to spell psychedelic and will never go to a rave, you know. But for those people to legally be able to receive this treatment, you know.
Yeah.
I want to see that before I die.
So Bill Richards, this person who just spoke, was a study therapist in this paper. You'll see on the left, Griffiths led it, and he recently died from cancer. This was published almost 10 years ago, in which they gave cancer patients, some of whom were approaching the end of life, 25 milligrams of psilocybin, and some received placebo with niacin, which causes flushing. And there was a crossover trial. So at some point, the people who received placebo ended up receiving psilocybin. And this was coupled with many, many hours of a kind of meaning-centered existential psychotherapy that Bill Richards provided. And you can see the differences in depression and anxiety were dramatic. There was a 60% reduction in people randomized to the psilocybin arm. And it even improved 6 months later in terms of depression. And in this other trial by Ross was done at NYU, and also dramatic decreases, 80% remission. These findings are unheard of in psychiatry with SSRIs and other medications. And interestingly, this sense of death acceptance also increased. This lack of fear or decrease of fear around dying was also a consequence in in the secondary analysis of this trial. These benefits were sustained from this one dose, 4.5 years, with 4.5 years follow-up. So at NYU, they looked at the patients who were still alive and found persistent decreases in anxiety, depression, death anxiety, hopelessness, and to some degree sustained improvements in the sense of spiritual well-being and faith. So 16 were still alive and 15 agreed to participate from the original group, and they showed sustained benefits. And one quotation that I'll share with you is, one of the patients said, "This experience changed my thoughts about myself in the world. I see myself in a less limited way. I am more open to life. It has taken me out from under a big load of feelings and past issues in my life that I was carrying around." Like I've mentioned, psilocybin has been used for at least 10,000 years by humans. There's evidence that it was used in the Sahara 8,000 years ago. So right now, the purpose of our talk today is to give you a sense of what the clinical trials look like in Switzerland, in the United States, in Canada. I don't know if these trials are being done in Iran, though they certainly could be, including the medicines that you have growing in your own country. There are many theorists that believe that the kykeon used in ancient Greece by the Dionysians involved these medicines, and that this work of using these psychedelics as sacraments continued on with the early Abrahamic religions, including in Zoroastrianism, the Homa or the Soma. We don't really know what it is, though people theorize that they were serotonergic agonists that were created in brews. So none of this is really new. And in ancient Greek, for people who went to Eleusis to drink this brew, there was the saying on the door, "If you die before you die, you won't die when you die." This is so popularized that at music festivals in the United States, they have this written. It's part of this culture now where if you are able to release your ego before death using some of these medicines with support, that perhaps when you do approach the end of life, you will have less anxiety. These were popularized in the United States in the 1950s when this man, Gordon Wasson, a banker in New York, traveled to Mexico and saw the work of this healer, a curandera, Maria Sabina, using these mushrooms to heal people in her community. He took this knowledge to the United States, and then this is how this ended up becoming what it is now in terms of scientific trials, 75 years later. The thing is, in our trials, our psychiatrists learned that when religious cultures use these medicines, they always combine them with some sort of community support. People don't use these alone. There is usually some expert healer, family, community supporting them. So a psychiatrist, this is many years ago, saw that in the Native American church, they would use music and religious pictures while people were on medicines. And that's what they started incorporating into our clinical trials. So some of our trials kind of look like this and are appropriated from these cultures. For example, in 1962, at a university in Boston called Boston University, there was a sermon in one of the chapels. And Walter Pankey was a divinity student. He was in our version of aphasia. And he gave half of the students who were listening to this sermon psilocybin, and half of them got a control, a placebo. And almost everyone who received the psilocybin believed they had one of the most profound religious experiences of their lives, listening to this sermon with this medicine. A famous scholar here in the West, said it was the most powerful cosmic homecoming I have ever experienced. And this is called the Good Friday experiment. And I'll just pass through this. Around the same time, a anesthesiologist and psychiatrist in Chicago started giving LSD to people who were dying from cancer in the hospital. And what he noticed was their pain would decrease, but afterwards, they began to talk about dying without fear. It was almost inappropriate, he believed. The relaxed sense of people saying that, of course I'm going to die, and that they were able to talk to their families about it. They were able to communicate love and feelings and resentments and joys and struggles in a way that didn't seem to be imbued with fear and suffering. And he found this to be very interesting. Communities in the 1960s, right? This was a very long time ago. This was when my father was a student at Danishgah Tehran. The hippies of the United States started using these medicines in healing centers. And they started dosing people who were approaching death with these medicines. And Stanley Grof, who was from Czechoslovakia, said, "It's hard to imagine a more useful way to combine medicine, psychology, and religion than this form of therapy." Later, he wrote, dying before dying has two important consequences. It liberates the individual from the fear of death and influences the actual experience of dying at the time of biological demise, which of course evokes this ancient Greek wisdom that was used for people doing this tradition thousands of years ago. This is Stan Grof now. He is still alive. And he also learned that you don't have to give medicine, of course, to stimulate these experiences. And he formulated a kind of breath work that I learned through him. And it's a kind of breathing over the course of 3 hours that could also evoke the sense of ecstasy or self-transcendence without the use of any medicine. Around this time, this is Spring Grove in Maryland. And in the 1970s and 1960s, they started giving these medicines with this kind of structure for people who were alcoholics. And one of the nurses on the team ended up being diagnosed with an incurable breast cancer, and they dosed her as well. And noticing her transformation, they realized, and they gave her LSD, that they should be studying palliative care and cancer patients in addition to people who were addicted to alcohol and heroin. This work ended in the 1960s because it became politicized for reasons that I don't have to go into today. You can look it up. And then they became illegal. And all of the research was shut down for about 30 years. And this research is now being done in very controlled settings with only doctors who have specialized licenses at a small number of universities in the United States. So now I've told you about some of these early experiments in churches, in addiction centers, and now it's 2020, and of course in psychiatry and depression and cancer. So now it's 2025. What does the landscape look now? And I'll tell you about this before I spend the last 10 minutes talking about my own research. So in Canada, because of advocacy, they now approve psilocybin to be used outside of clinical trials and to be given compassionately to people who are dying. And now at least 100 people have been given this medicine. Interestingly, many of the doctors who are doing this work are Iranian. Either they were born and raised in Iran and now live in Canada. And they are the ones who are doing this work. I find the intersection of people of Iranian ancestry who are doing this very intensive spiritual work to be very fascinating to me. People in the United States who are dying do not have this access like they do in Canada. So they are petitioning to be able to use this medicine outside of clinical trials for people approaching death. People also travel to other countries to receive this treatment. So in South America and in parts of Europe, people will fly there to receive this treatment. And oftentimes it looks like this. People are sitting in a circle. There is a physician on staff to make sure that people are safe, and they're administered these medicines. In our clinical trial spaces in palliative care, we are increasingly using people with some degree of spiritual health training. These are not religious scholars. These are people who support people with issues around religion, theology, existential crises, and spirituality, because these things are so salient with these medicines. There are Christian organizations in the United States that are trying to find ways to support Christians through these experiences. There are Jewish organizations, and this woman, her name is Sugra Ahmed. She is the primary chaplain for Muslims at Stanford University in California. And she is starting her own group called Rohani, and for people undergoing these experiences, including in clinical trials in psychiatry and palliative care. So she is looking for a way to support Muslims who go through these trials. And at my university, we are going to publish a study soon about Muslims in America and their attitudes towards psychedelics as well. In Dubai, there was a group that recently met to advance, these were mostly psychiatrists, to study these compounds in the Arab world, and they met within the past year in Dubai. So a couple more minutes about what this looks like in hospitals. So about once every 2 weeks, I am doing something like this. This is at Johns Hopkins. This is the room where we ask people to take these medicines, put a blindfold on their eye. They listen to music for about 6 hours. The music is very emotionally powerful. And we have 2 people in the room to support them through the experience. It's very averbal. Very little is said through words because most of the experience is averbal to begin with. And then, the next day, then we start talking about it. And at NYU, they administer the capsule using chalices almost as a sacrament. These are other rooms. This is in Wisconsin. This is in Utah, where these empty seats are for the patients, and then the people that you're looking at are the therapists and the psychologists and the psychiatrists and the nurses who are supporting people. This is a bone marrow transplant infusion suite where people receive chemotherapy and other cancer-directed therapies. On the weekends, however, they transform these spaces into vibrant settings where people are then dosed with these medicines with psychiatrists and psychologists supporting them. And a form of this tradition is to have fresh flowers for the patients. And this has been going on for 75 years. So in these chairs, on the weekdays, people get chemotherapy, and on the weekends, they receive these treatments. This is what it looks like in London. And these are my colleagues at Harvard. The woman you see in front is of Iranian ancestry, and she is a very good friend of mine. And she is a psychiatrist and a psychoanalyst at Harvard University. Her name is Roxana, and she's a genius. So in their hospice affiliated with Harvard University, this is where they dose it. So people go from home to the hospice to receive the medicine. This is for one day. Then they go back home. And then some of them, when they are within 1 or 2 days of dying, they come back and they die in the same room where they received this treatment. And again, just more examples of what this looks like in hospital settings. So palliative care comes from the word pallium, which is to hide or to cloak, to numb. It means something anesthetic. These are not anesthetic, these are aesthetic, meaning they amplify emotions. They make the pain worse. They make the depression worse during the treatment with the hope that that stress will allow you to work through it with the support of psychotherapy to then improve. I have 10 minutes left, so we'll get close to wrapping up. All of these trials include preparation for several weeks, generally with some sort of psychotherapeutic model, CBT, ACT, etc., including instructions for what the dosing day will look like. Then it involves 1 to 2 dosings generally, and then you have several weeks of unpacking that experience. And so my trial looked at using this medicine in early palliative care. So I see patients who primarily have demoralization. Demoralization is a syndrome of a sense that you can't cope with what you're given, a sense of meaninglessness, helplessness, and poor self-esteem. Many people with clinical depression also have demoralization, but not all people with demoralization have anhedonic depression. For example, I can have a patient who, in palliative care, who is demoralized, who wants to die. But if they like cake and you give them cake, they will really enjoy the cake. But after they finish eating it, they say, I still want to die. My life is meaningless. It is purposeless. I am just a burden to my family. Classically, a person with anhedonic neurovegetative depression would not enjoy the cake. So that's what makes you think that they're different situations. I'm just going to skip through a couple slides for the sake of time. So in my clinical practice, 77% of patients have chronic pain. And with an alpha of 0.05, it is significantly associated with all of these other things. So they come together very closely. And same thing with demoralization. 2/3 of my patients have this sense of not wanting to live anymore with whatever they have that is associated with pain, depression, loneliness, death anxiety, PTSD, and the sense of you want to avoid what's coming. So in palliative care, and at least in the United States, we have this model where we have physicians, nurses, social workers, and chaplains. I don't know what the equivalent of a chaplain is in Iran, so we could discuss that later. But spiritual leaders. And how we made this look is that we had a patient, and then to his right, on the left, we have a spiritual advisor. He also has a PhD in psychology, but his role is a spiritual advisor. And again, he is a Christian, but he cares for Muslims, whoever it is. So it's not like he is imparting his Christianity to other people. He is supporting anyone's spiritual health. And then on the right is a mental health counselor. We call this at our university the triad model. So they received one high dose of psilocybin. And these were people who were living with cancer for at least a year and who were not imminently dying. They had a prognosis of 6 months or more. We dosed 10 patients. This was a pilot trial, 5 of whom had advanced cancer. The intervention was safe with no serious adverse events. And interestingly, 7 out of 10 of these patients said it was one of the top 5 most meaningful and educational experiences of their entire life. And 6 out of 10 said it was one of the top 5 most spiritually significant experiences of their entire life. We looked at all of these exploratory outcomes, such as anxiety, depression, pain, demoralization. And because this was a pilot trial, I'm not going to share standard deviations with you. I'm only going to share with you the median number. So at a level of 10 is clinically significant demoralization. At baseline, they were at 20. After dosing, they went to 6. Again, less than 10 is remission. And then 3 months later, they stayed at 5. So I would call this a hypothesis generating success. And these are the box plots with the 25th and 75th percentiles. So you can see, though the median decreased, that's the line, there were some non-responders. We had 2 non-responders in the group. With anxiety and depression, at baseline was 12 and 10, decreased to 6 and 5 post-dosing, and stayed decreased 3 months later. And again, the box plots. I don't know if you use the ESAS in Iran, but this is the global assessment of symptoms. So from nausea, fatigue, depression, anxiety, pain, we have a composite score. So they started at 50, and then 3 months later, we're at 14. We had one patient who was using opioids every single day, and he has been off of them now for a whole year. He is still alive and has not required opioids. Pain catastrophizing is when you amplify, when you have an emotional response to pain, including rumination, magnification, and a sense of helplessness, which is very similar to demoralization. So people started at 25, post-dosing was at 14, 3 months later was at 7.5. So for physical pain, people had on the brief pain inventory, out of 10, an average score of 5. This is the median score of their average pain. And 3 months later, decreased to 2.5. Same with mood, a dramatic decrease, and also the effect of pain on enjoyment of life. Importantly, the day of dosing, the pain did not improve. For some patients, the pain worsened during the day of dosing, but then months later, the pain decreased by at least 50%. And these are, again, the box plots. Huge variability, you can see. And again, it's only an N of 10. We used the Harvard Flourishing Measure to measure overall quality of life, with 1 being the worst and 10 being the best possible quality of life. At baseline, the median was 2.5. At the end of the study, it was 8 out of 10. And then 3 months later, it was 7. And again, there's the box plot with, again, some non-responders. A couple minutes left. So what patients said was most salient or important was that they were able to have rapport with their therapist. They trusted their nurses, their doctors, their chaplains enough to be able to release into the experience and uncover or excavate personally meaningful insights that they believed were sacred or holy or spiritual. And I know we only have a few, oh, actually, we have a couple minutes left, so I'll keep going on this slide. the acute effects of psilocybin are 6 hours. So we would dose people at 9 in the morning and tell them to leave at 5 or 6 p.m. Some people wanted to sleep there overnight. They thought that it was so powerful they couldn't get home. One patient said, I wasn't ready to leave. And when I got outside, I had to hug a tree before I got in the car to ground herself. Like my portal is wide open and I can't get in the car. So I stood there holding a tree, just trying to get myself grounded enough to be able to get in the car and go home. So that's how powerful these things are, even at the end of the day. So unique considerations for cancer care or palliative care. I'm going to start studying Parkinson's and neuromuscular disease as well, is that we can think beyond depression and anxiety in these trials and think about the intersections of pain and hopelessness in these trials. Our patients are very sick, so these are not typical psychiatry trials, right? So in the psychiatry trials that I do, patients can't be on pain medicine to enroll in the trial. However, that would be unethical in palliative care to withhold pain medicine for these trials. So our patients have lots of medications. They're hospitalized frequency. So this is a sicker population. I might come back to this in just a minute. So how do we support people through these transformations? At the end of our trials, our patients really wanted us to connect them with group therapies. So we created a group acceptance and commitment-based psychotherapy for these patients. And our next step is to really connect with community organizations, with masjids in Atlanta, synagogues, temples, churches, to help people who want to have some sort of additional spiritual support that's consistent with their belief systems, whether it's Buddhism or Islam, to support them after these trials are over. And in the last 5 minutes, I'm going to show you one of the dosings. This patient consented to be filmed during his first dose.
Yes, sir.
He's at the time was 29 years old with Ewing's sarcoma and had just had surgery, chemotherapy, and radiation, and was very demoralized. He was also temporarily homeless during this trial and required the support of the entire palliative care team.
Hours long, from 9 a.m. to 5 p.m. The experience from the psilocybin will last 4 to 6 hours.
Oops, sorry. Let me try that again.
Just inhale.
Wesley notices sensation.
Okay.
Thanks, John.
Welcome. All right. So, Lisa,
See you on the other side. Thanks.
Within the first hour, Wesley notices sensations.
It's maybe a little tingling. It feels good though. Feels really good.
He says he feels a shift in his body.
Felt really hollow for a really long time. So it's nice to like inhabit my own body again. So it's weird like being all the way in my body again. Feels really nice not to be so rigid for once.
He seems to soften toward himself.
I guess there's that spark of the divine in me. I've already got the white light that I need. That's cool to say out loud. Yeah, you know, seeing that like goodness in myself for once. Maybe the first time. I think I've always felt it, but I've never been able to like get this close to it. Really peaceful. It was scary how relaxing this is.
Enjoy it.
Yeah, this is wonderful.
In the second hour, his experience intensifies.
Shaky now. Like internally shaky. Yeah, it's a little uncomfortable now. Yeah, well, one of y'all might hold my hands. Well, that might be nice. Maybe both of you. Both of you would be pretty cool.
He grieves his cancer diagnosis.
I really give myself much space to grieve that 27-year-old version of me.
right.
And the loss of his father.
About to be a son. We did really good work together. Ruthie said that's over.
And then he says this about the cancer he has feared will return.
The cancer's gone. It's not coming back.
George takes Wesley's vitals every hour, his blood pressure and heart rate.
You're just in a really like intense phase of the adventure right now. Oh boy. A little scary, I'm not gonna lie. Yeah, I really appreciate y'all being here to hold my hands throughout this.
Wesley shows George and Shannon the scar from his spinal resection to remove the cancer.
Yeah.
Wesley lies down and closes his eyes, and for the next hour he is quiet. He looks peaceful. At times there is a smile on his face and quiet laughter. And then he is back.
It's just nice to be back on Earth for a few minutes. Not quite sure where I went. It was a lot of fun, but very nice to feel that connection again.
You're fantastic, Mom.
Yeah. Wesley's eyes changed after that dosing, and he is still getting treatment now. His cancer returned, and he is now training to be a chaplain himself. It's very interesting. He is an atheist. He does not believe in God, but he is in a seminary right now, receiving a master's degree in religion. It is a And none of us imposed this on him. This is medical treatment, right? So these are I'll conclude by saying these are very powerful tools that can be easily abused. And to what degree has this been transformative for us? I live in the Western world, in a secular society, in a secular healthcare system, and it's been fascinating to support patients through whatever journey it is that they're going on, and to respect whatever their transformation is. The very last thing I'll say is, I don't live in Iran. It is your society, and these medicines exist in every continent, and they can be abused, right? And drugs can cause problems, many problems. Though when it appears in these trials, when they are used only once or twice in very supportive conditions with lots of monitoring, support, and psychotherapy, people tend to have fantastic, life-changing outcomes. And this is our team. I'll stop my screen share. And it was, thank you so much for letting me, anything else? Yeah, thank you so much for giving me this opportunity.
Thank you very much, Dr. Aljon. Zarrabi, thank you for your excellent presentation. I enjoyed it. For me, the topic was new exactly, and interesting, practical, and impactful, and I am sure the participants also enjoyed your excellent presentation. Of course, I attended in your session in a palliative care conference in Canada, and it was part of that, but I was a little bit familiar, but I am not sure in Iran. Most people know in this topic, but as this topic is mostly related to Dr. Nejati Safa specialty and other participants in attending this session, and I hopefully anybody had a question, write in a chat box, and also or if they wanted to ask a question, they can raise their hands. But I want to invite it, I want to just clap hand for you, because, and maybe the participant also can reaction in the chat box to Dr. Aljon Zarrabi, because Dr. Aljon Zarrabi is so keen and interested to collaborate with the Iranian colleagues and researchers in Iran and Tehran University and other university in Iran or other country, but I'm not sure from which country the attendee joined in this program. Please write down in the chat box which country, city, hospital, or university and join this program and what is your specialty. Then I would like to invite the Dr. Nejati Safa continue and lead the session. Dr. Nejati Safa, can you hear me?
Yes, thank you, Dr. Zarrabi, for your fabulous lecture, and Dr. Hassanpour for her role as a moderator. The application of psychedelics in palliative care is fascinating, I think, and I learned from your lecture very much. Actually, a little storm is occurring in Tehran, and sometimes the power is going out and then return. Sorry for the turning off the light and turning. I'm waiting for the question and comment of the participants in this session.
I think somebody raised their hands. I have to check. And can you see that one?
If there are questions, I will be grateful.
Oh, okay. So can we apply this therapy in pediatric populations because they experience total pain during end-of-life care? There is a doctor he was from the United States. He moved to London. His name is Elisha Waldman, and he is a pediatric oncologist and palliative doctor there. And he wants to study this in adolescents, so people probably 13 and older. Nobody has done this yet. I think many people are nervous to give a pediatric population this medicine. I think many of us are also nervous to give this to people very close to death, right? Because if all of a sudden your opinions about who you are and who you function in the world shift, and then you have 2 weeks to live, that can make, we call it ontological shock. It can make you more anxious. So I'm giving you two answers. My preference is to do this earlier in the setting of a serious illness for total pain, to give people the time to integrate before death. With the pediatric population, nobody knows. I'm not a pediatrician. I'm scared about it, though someone is going to do it soon. Hello, Nassim from Kermanshah. My family is from Kermanshah, and I visited maybe 20 years ago. I love it there. Yeah, and I really want to emphasize that this is not mainstream in palliative care. There is a small group of us who have a lot of interest in this, and at the same time, it's one of the main reasons why it is not standard of care for palliative care is most people don't want to have more stress and more work and 7 weeks of intensive psychotherapy with a serious illness. Most people want lorazepam or morphine, right? The people who are enrolling these trials are demoralized, right? They're hopeless, but not hopeless enough to not want to enter something to change. So this is not for everybody. There's a certain degree of bravery to anyone who wants to be a participant in this kind of work as a therapist or as a participant, as a patient. There is a bench scientist in Arizona in the United States who compounds these medicines for phase 1 clinical trials. And I'm going to ask her to do it for SVAND. And I really want to do my next study studying wild rue in palliative care. But I mean, it is, you know, you can do it too, depending on the laws of your country. Don't do anything illegal.
Thank you, Dr. Zarrabi. I have a experience of using SVAND in one of my patients. Actually, one of my patients used SVAND as a tea, named in Iran Jushunde. They use, and after several weeks, unfortunately, he became psychotic, and
Yes.
we must admit him in hospital and treat him as schizophrenia-like psychosis. Actually, I think we should use these substances with caution. And my question is, what kind of supervision we need when we use these medications or psychedelics?
That's a very great question. So these are patients who are very carefully screened. So they cannot have a personal history of psychosis, no personal history of bipolar 1. If they have a family history of schizophrenia or bipolar 1, they cannot enroll in these trials. We check their QT interval, so they have to have a QT of less than 450 on their EKG. And in terms of monitoring, you can see there are 2 people in the room checking blood pressure, heart rate every hour. And then outside the room, you have me, an internist, you have a psychiatrist. We have all of these rescue meds. So we have blood pressure medications, we have antipsychotics in the room. So everything is carefully screened and monitored. So let's say, for example, if it were to be an SVAN trial, it would be 1 high dose for someone carefully screened. But the idea of using these medicines are also called psychotomimetics. They induce psychosis. And that's how they were originally studied in the United States in the 1950s. So that's why Paracelsus said the dose makes the poison. There's a narrow dose range that we use for our patients, determined by phase 1 trials for people who were very carefully screened. Yeah, once people just start using these medicines out in the public is where addictions and tragedies begin, and that's when they become illegal again. So every society needs to figure out their relationship with drugs that induce psychosis. And the ways in which we're doing it in the medical system is to have these experiences be highly monitored.
And thank you, Dr. Zarrabi. And I have another question. What the best route of administration of these drugs? For example, for ketamine, we use a kind of a spray, but for psychedelics drugs, the best route of administration.
And so I should also be clear, psychedelic is also a dose range. So ketamine, for example, Spravato at 50 milligrams or 80 milligrams is unlikely to give you a consciousness expanding experience. However, when administered intravenously at 0.5 milligrams per kilogram over 50 minutes, and you don't pre-medicate it with a benzodiazepine, that's considered to be a psychedelic-ish dose. Also, intramuscular ketamine is the most powerful version. So at my university, I'm going to publish a case report on this soon. We are using the same music as the mushroom study and the blindfolds and the whole production using intravenous ketamine. for people with cancer-related total pain. So it's the intentionality, it's the dose, it's the supervision, and it's the route of administration. Because intranasal will never give you, I mean, at least the doses that we use in America, the same effect as a psychedelic range that's intravenous. And of course, if you give too much, then it's anesthetic. It's anesthesia, right? So it's you have the anesthesia dose, you have the psychedelic dose, and then you have, you know, Spravato or the intranasal.
Thank you.
Yeah. Well, I wonder if it is time for, I know it's the weekend for you, so if it's time.
May I just ask a question, Dr. Zarrabi? I wanted to know when you're working with this patient and you're just implementing this kind of the therapy, what's your reaction or what's the effect of that reaction on the therapist or you as a
Oh, yes.
therapist?
Yeah, we
And
studied this.
how
If you look at the journal is called Psychotherapy. We published a paper in that journal maybe a month or two ago because we asked the therapists, what was this like for you?
Yeah.
Um, uh, what they thought the combination of the religious person, the therapist, and the patient was very new to them. This is not typical in American medicine. And they thought addressing issues of connection with the self, connection to somebody else, connection to something greater than you, and connection to nature that the chaplains were able to bring was very beautiful. Um, they also, and we haven't figured this out yet, they wanted to be able to choose the patients they would work with. Of course, there's a lot of transference and countertransference. So if you're going to be working with somebody for 25 hours in these settings and you don't feel a good connection with them, they wanted to have the ability to choose the patients they wanted to work with, which we have not yet allowed yet because we don't have enough therapists. That's probably the main reason who do this work. But
and we have to say the therapist choosing the patient or patient choosing the therapist.
both,
Because
both.
the connection is very important, I think, for the spiritual, just the soul, and you have to connect it very well with the patient. And
Exactly. So the patients never said, I don't think the patients knew they could have a choice, but the patients never said that they wanted to choose their own therapist, but the therapists knew because the patients did not connect with them that they wish someone else had done the work.
then you are referred to another therapist, maybe.
Yes, yes. What some did mention is we had some patients of African origin, African American or Black Americans, who really liked having a Black therapist. Among people with religious devotion, nobody really mentioned that they wish they had a therapist of the same religion. However, after the trial, they wanted the therapist to connect them to someone from their religion to support them, but they were afraid that the religious person would not believe the importance of what they went through, which is why we have Muslims, Christians, Jews, etc., create organizations where these people feel welcome after these trials for depression or palliative care, that then the main result was to make them feel more connected to God or whatever it was. It's
And also we
yeah.
And also we can start it from the early of the diagnosis of the patient with the complex disease or illness, or we have to go to the end of life. What you recommend for that when we can start it and more effective?
I think in palliative care it should be early.
I know.
Yeah.
But for this kind of the therapy is the same of the palliative care. You have to start it early as the diagnosis for
as early as I mean, nobody has studied that comparing both. I think Our colleagues at Harvard recently completed a trial. We finished it at the same time, and they were looking at people within 6 months of death. And it was just, they were very weak. It was very hard for them to do this work. So, and only out of 100 people that they screened, only 1% qualified because of cardiac abnormalities or electrolyte abnormalities. So it's much easier to enroll people in these studies safely who are not very close to death.
Thank you very much.
Dr.
Dr. Negati Safa, you can continue. Sorry, I just interrupted you.
I have two more questions, Dr. Zarrabi. The first question is about the financial issues in this kind of treatment. I don't know the cost of your treatment, but do you have any opinion about the coverage of insurance company in the United States for your treatments?
Well, these medicines are still illegal, so they can only be studied in clinical trials. If they were to become legal, the expense would not be the drug because the drug is cheap. It's the therapy. So it's the therapist's time that you'd be paying for. So the question is, part of the reason why we actually used chaplains instead of two psychotherapists was because chaplains are cheaper in America. And they actually want to do this work for less money than a PhD psychologist. So it was a cost-saving measure. Also, there's a group that does group therapy. So if you're doing multiple patients at once, it's more cost-effective. What I think will happen in the Western world is more and more of these treatments will be group therapy, unless you have lots of money, in which case you might have individual.
Thank you. And the second question is about the use of this kind of treatment in out of the hospital settings, because in Iran we don't have hospice, and some palliative care experts believe that we should provide palliative service in outreach mode and something like home visits and providing palliative service in home. Do you think that this kind of treatment can apply to such kind of services for palliative care, for example, in home treatment with psychedelics?
Yes, so in the 1950s and the 1960s, before these medications became illegal in America, people would dose these psychologists, they were primarily psychologists, would go to people's homes. There was no psychiatrist involved, and they would give these medicines. I think right now, if that were to happen, people would have to be very closely monitored prior to dosing, and there would have to be more of a risk because if someone were to develop a psychotic break or were to have a cardiovascular event, there wouldn't be the same degree of support, right? So right now we're doing these in very carefully monitored settings because we don't, if people get harmed, then we can't continue the research. Though with compassionate use in Canada, they are doing it at home. Yeah.
Thank you very much. Thank you.
Well, it was such a pleasure to speak for this international group and to the university that trained my father. And if there are no other questions, I just want to express my deep gratitude for being able to present to you today.
Dr. proud of you and your father. God bless him and trained as such a nice person, nice scientist. I'm exactly proud of you. I met you in person in Canada and now virtually, and I hopefully we can continue more collaboration with you and your center, hopefully in the future with the Aladdin House scientific collaboration of the Tehran University, and also Dr. Nejati Safa also have a comment for that. But I'm really proud of you. Thank you so much. Anybody have more questions? Please raise your hand. Give comment. Nobody? No comment? No question?
Thank you, everybody. Thank you, everybody.
Thank you, Dr. Zarrabi. Thank you.
Enjoy the weekend. Bye, bye, bye.
Thank you very much. One more time I express my sincere thanks to Dr. Zarrabi, Dr. Nejati Safa, Dr. Yaghmoui. If the Dr. Yaghmoui have any comments, questions, would you please raise her hand? Dr. Yaghmoui is in the flying. I think he's the Air Force, and couldn't just hearing the write a comment. She's hearing. No, but she's in the airport at the moment. Thank you very much, everybody. All participants joined from different, I think, the city, different university, and the hospital here. We have the many participants at different parts of Iran, and also our students from Africa and other countries also joined this program. All of the participants, the certification will be available in 7 or 10 days after this presentation, and also the recorded presentation will be available in YouTube for all of the participants and other people. Thank you very much, Dr. Zarrabi, Dr. Nejati Safa. If any more comment or for the end of the session, please welcome.
Thank you, Dr. Hassanpour, and I should also gratefully thank Dr. Zarrabi for her participation in this session, and hope to see him in Tehran very soon.
I hope. We'll see.
Yeah, hopefully in person. Thank you very much.
Thank you, Faina. Bye-bye.
Thanks, and take care of yourself. Enjoy your day. Thank you very much. Bye-bye.
Bye-bye.
Bye.